All right. Thank you, everybody, for joining in person. I see at least there's 26 online too, so thanks for those who are online. Our pleasure to start the 2025 Lifespan Comprehensive Sickle Cell Center didactic sessions, research meetings, and look forward to a jam-packed 2025 schedule, of which I'm not sure who's presenting the rest of the year, but we'll get that out to you. We are very excited to have Dr. Annam today coming to us from Texas Children's Hospital. It's obviously always a pleasure to have junior people here. And is this your first national talk? At least looking through the CV. Your 20th? Perfect. So we're excited again just to be able to give junior people the opportunity to come here and present on their early career research. So Dr. Annam completed her medical degree at Duke, her pediatric residency at Lurie Children's, and then she did a fellowship at Baylor Texas Children's Hospital. And she currently continues there in research, holding the position of instructor of pediatrics. She completed the prestigious PRIDE program. I know some of us at UAB have done that through Augusta University, and she's currently funded with NIH Loan Repayment Award through NHLBI, which I know is always very welcome and exciting to have it achieve that award. Her research mission is to understand the mechanisms of cardiopulmonary complications in sickle cell disease through innovative translational research. She currently, I think, is still awaiting a KO1 score that she submitted to NHLBI, and it's on some of the stuff she'll present here in terms of BMP9 and sickle cell. And she has some additional funding as a co-I for an R01 studying inflammatory caspase activity in sickle cell, and has a Jean Marie Lucier Award to study acute chest syndrome. Since 2022, she's had 5 publications and 5 additional ones in preparation. So again, very excited to see your progress, and has been both ad hoc reviewer for leading journals in the field and abstract reviewer and moderator for the ASH annual meeting. So with that, again, very excited to introduce Dr. Annam.
Thank you for that introduction. I was impressed. I was like, who is that? That's me? Okay, great. So thank you all for having me, and I'm super duper excited to share with you a topic that I hold near and dear to me, and that is acute chest syndrome. And today I want to take you on a journey from the past, the present, and the future of acute chest syndrome management. 1 second. All right. Okay, so I only have one disclosure that doesn't include financial. I'm a pediatric hematologist, so some of the topics and how we'll present today will be pediatric focused, but I will note when that is the case. And I also invite your perspectives, both those who are adult hematologists and then just as a part of the UAB system, because I think it's important to think about sickle cell disease care and acute chest syndrome management care across the lifespan, and then also across different systems. All right, so I want you all to take away really 5 major points. First, to be able to define and diagnose acute chest syndrome, to be able to classify acute chest syndrome by clinical severity, and we'll talk a little more about how to do that. How to identify patients who are at risk for severe acute chest syndrome, the ability to be able to appropriately manage acute chest syndrome based on current guidelines. And then I want to close with talking about potential biomarkers and therapies for specifically severe acute chest syndrome. So as many of you all know, sickle cell disease is one of the most common inherited red blood cell disorders whose gene mutation can cause hemoglobin polymerization and sickling of cells. And this can lead to physiologic manifestations, notably chronic hemolysis, endothelial dysfunction, inflammation, and vaso-occlusion. Clinically, this can present as moderate to severe anemia, acute and chronic pain, and most notable for this talk, acute lung injury and cardiopulmonary disease. Now, focusing on the latter, acute chest syndrome is a form of acute lung injury, and it's seen in people with sickle cell disease. And importantly, it's one of the leading causes or morbidity and mortality in both children and adults with sickle cell disease. And at least half of individuals with sickle cell disease will have at least one episode of acute chest syndrome in their lifetime. And although it can appear clinically very similar to bacterial pneumonia, the pathophysiology is thought to be multifactorial, consisting of this interplay between vasal occlusion, inflammation, and hypoxic lung injury. So, how do we define acute chest syndrome? Well, based on NHLBI guidelines, acute chest syndrome is defined by the presence of a new segmental pulmonary infiltrate, as seen in that image to the right, and at least one of the following additional findings. So either fever greater than 38.5 degrees Celsius, oxygen desaturation at least 2% below baseline, respiratory symptoms, which include cough, shortness of breath, retractions, chest pain, and abnormal lung sounds such as wheezing or crackles. Now that we've defined acute chest syndrome, let's learn a little more about managing this complication, and let's start from the past. So I found two papers in the late 70s, early 80s that discuss acute chest syndrome management. And the first is from the Archives of Internal Medicine, which is now known as JAMA. And it highlights the mainstay of care for patients with acute chest syndrome, and that was supportive care at that time. And transfusion recommendations were based on clinical status and reticulocyte counts. And antibiotics were only reserved for based on sputum results and severity of illness. And at this time, the pneumococcal vaccine was very new and its efficacy had not yet been proven. 5 years later, there was a Lancet paper that retrospectively reviewed the clinical course of 13 adult patients with acute chest syndrome over a 5-year period. And here, they describe the management, which includes IV fluids, FFP, interestingly enough, and analgesia. And by this time, antibiotics were routinely given, and exchange transfusions were only recommended in very, very severe cases. Now, 20 years later, the great Dr. Elliot Vichinsky and colleagues from the National Acute Chest Syndrome Study Group published a retrospective multi-center study that included data from over 500 patients and over 600 episodes of acute chest syndrome. And the first thing I want to highlight from this paper is that the standardized treatment protocol for the patients included oxygen therapy, antibiotic therapy consisting of a cephalosporin and a macrolide, at this point, erythromycin, fluid management, and they recommended 1 to 1.5 times maintenance, respiratory therapy, which included incentive spirometry protocol, pain management protocol, bronchodilator therapy, especially in patients with evidence of reactive airway disease, and then transfusion therapy given to patients with clinical distress, and it was based on physician discretion. Other things highlighted were bronchoscopy, and also things like steroids and nitric oxide. And these were reserved for patients who didn't respond to the initial therapy listed. Also mentioned was mechanical ventilation and ECMO, and this was reserved for severe cases of acute chest syndrome. And then other disease-modifying interventions, hydroxyurea, chronic transfusion, and bone marrow transplantation were in consideration for those who had recurrent acute chest syndrome events. The second aspect of the paper I want to highlight is that they determined the cause of acute chest syndrome in about 70% of cases, and this was based on laboratory and biopsy data. The most common cause was thought to be pulmonary infections, and then also fat embolism from marrow necrosis. But that left about 30% of cases with an unknown etiology. And based on what they posited, they thought that the reason was pulmonary infarction. And so it wasn't necessarily proven, but that's kind of what they kind of concluded. And so summarizing the management of acute chest syndrome based on the determined causes at this point over 2 decades ago, we have red blood cell support and modulation, which includes transfusions, hydroxyurea, and transplant. From an infectious disease standpoint, we have penicillin prophylaxis, vaccinations, and then macrolide and cephalosporin for acute management. Other things include incidence spirometry and pain management to reduce the risk of hypoventilation and atelectasis. And then from oxygenation support, so supplemental oxygen in forms of both non-invasive and invasive mechanical ventilation. So given this, where are we with acute chest syndrome management? Have we made much progress? Well, let's see. Let's move into the present. So first, I want to start by listing some risk factors that have been determined over the past 2 decades based on multiple studies on acute chest syndrome. So as you see on this list, some of those risk factors are more modifiable than others. And I specifically want to highlight that young age is associated with increased incidence of acute chest syndrome. However, when we think about severe acute chest syndrome, it's the adolescents and adults who are at the most increased risk. And one of the studies led by one of my mentors, Dr. Shruti Chaturvedi, found that thrombocytopenia was the sole predictor of rapidly progressive acute chest syndrome, which has been also associated with multi-organ failure. Also, cardiac disease and multi-lobe involvement for respiratory failure were also associated with severe acute chest syndrome, and this was based on the Vichinsky paper mentioned previously. So based on that information, the way that we, initiate our evaluation and workup of acute chest syndrome, it's based on symptoms and findings such as vitals, things on chest X-ray and labs. And then we will also obtain blood cultures and a type and screen for future management planning. In terms of initial management, in a combination based on NHLBI guidelines and what we typically approach, how we approach acute chest syndrome at our institution, most of the time, almost always, if there is an acute chest syndrome diagnosis confirmed, then we typically admit our patients. We also will give broad spectrum antibiotics, typically ceftriaxone and azithromycin. In discussion with some of my adult colleagues, moxifloxacin is another antibiotic that is used. And then in our patients with severe illness, we typically broaden coverage with vancomycin. We typically provide supplemental oxygen to maintain saturations above 94%. And then we are thoughtful about our IV fluid management, really just to try our best to avoid fluid overload while making sure that we're doing what we can to decrease sickling. So we typically use 3/4 to 1 times maintenance. And we also take into consideration the oral fluid intake as well. We also try our best to be very big on the incidence spirometry at least every 2 hours. When I round on patients, I ask, where's the incidence spirometer? And if they don't know where it is, that's a problem. So we either we find it, if it's in the room, and if it's not in the room, we talk to nursing and staff to make sure that's in the room. And then if there's wheezing on exam, or if the patient has a history of asthma, we will consider bronchodilators, plus or minus steroids. And I take a pause with steroids because I know it is a controversial topic, especially with my adult colleagues. And a lot of it is based on studies that have associated the use of steroids with rebound vaso-occlusive episodes and admissions and longer length of stay. At least in our institution, especially if the patient has a history of asthma, like I said, wheezing, we will typically give steroids, but we will consider doing a taper to make sure that we're reducing that risk of the rebound complications. So that's typically how we approach that. And then the last point, treating pain. So it's really important that we try to adequately manage pain sooner than later, especially knowing that, studies have shown that with acute chest syndrome, it usually presents on average between 2 to 3 days after the onset of a vaso-occlusive episode. And so getting ahead of pain is going to be super important, while also making sure that we're minimizing oversedation, which can also cause respiratory challenges. Transfusions are another mainstay of treatment in acute chest syndrome. Based on NHLBI guidelines, which we typically follow, we will consider a blood transfusion if the hemoglobin is greater than 1 below baseline, definitely if it's below 2. We typically will give 10 per kilo of PRVCs in our smaller children. Older children, young adults will start with 1 unit and reassess. But if the baseline hemoglobin is already over or about 9 grams per deciliter, they may not need a simple transfusion, especially in mild to moderate cases. Um, and then for our more severe patients with acute chest syndrome, we will discuss exchange transfusion, especially in 2 scenarios or 3 scenarios, really. If one, the hemoglobin is rapidly declining, two, if the patient's already presenting with severe acute chest syndrome and their hemoglobin's like 10 or greater. And then also, if the patient is so severe that we're considering intubation, at that point, we would likely perform exchange transfusion. That'll give us an opportunity to place a line under sedation and get our renal colleagues involved who help with the pheresis aspect. However, there are some of my colleagues at Texas Children's who do take pause with exchange transfusion. We did have a pretty devastating case that there was a patient with severe acute chest syndrome, had a pheresis catheter placed, and very soon after developed a massive PE and cardiac arrest. And the thought was likely due to the pheresis catheter causing a thromboembolic event. But this is a good segue into something that we did based on that study or based on that outcome, and then just thinking about the thromboembolic risk in our patients, especially the children with sickle cell disease. In adults, VTE prophylaxis is pretty standard. And so in collaboration, led by one of my good colleagues, Dr. Shreya Argaval, we actually did a retrospective review looking at our patients at Texas Children's and looking at their thromboembolic events. And one key thing that we found is that patients who have acute chest syndrome, they had a higher risk of having thrombosis compared to patients who did not present with acute chest syndrome. The other cohort were patients who were in the ICU. And so we developed a standard practice that we do follow at our institution. And so patients will get VTE prophylaxis outside of like the adult population if they are 12 and older with acute chest syndrome. And then if they are less than 12, if they end up in the ICU for any reason, we will also provide a VTE prophylaxis. So medications that we typically use, rivaroxaban is becoming kind of our go-to unless contraindicated based on several impressive trials. But we also will do enoxaparin in specific populations as well. In unstable patients, unfractionated heparin is our way to go. And in the event that a patient or a family declines our typical medication management, then we would use SCDs. Now, I know you've heard me talk a lot about severity, and there are a lot of questions about like, how do we define severe, moderate, mild acute chest syndrome? So there have been several papers that have highlighted the differing severity of acute chest syndrome, but for a long time, there wasn't a clear classification system established. So in an effort to both acknowledge and define the range of severity in acute chest syndrome, the NHLBI-sponsored Comprehensive Sickle Cell Centers Committee developed the Clinical Severity Index. And this retrospectively classifies the outcome of an episode of acute chest syndrome by clinical features and interventions provided. And for example, as the severity category increases, you notice that the degree of hypoxia, numbers of lobe involvement on X-ray, level of respiratory support, and amount of blood and type of blood transfused increase. In the mild to moderate categories, if at least one factor is in the severe category, they're moved up to the next severity level. And as you see in both the severe and very severe categories, respiratory failure is a key feature. And the definition of very severe acute chest syndrome is essentially the same as the definition of acute respiratory distress syndrome. So we talked about retrospective classification of acute chest syndrome, but how do we prospectively look at acute chest syndrome and provide interventions based on that? So Texas Children's Hospital, in collaboration with our hematology, pulmonology, and emergency medicine colleagues, developed the clinical respiratory score. And it was initially designed for children presenting with asthma exacerbations and was later adapted for our hospitalized patients with sickle cell disease with or at risk for acute chest syndrome. And it includes 6 categories. that include assessing respiratory findings, use of accessory muscles, mental status, and their oxygen saturation. And then each category has a subscore ranging from 0 to minimal change to 2 for significant change in clinical status. And so that composite score will range from 0 to 12. And scores are typically assigned and documented by either our respiratory therapy staff or by nursing. And it's recommended to be assessed at minimum every 4 hours. And at our institution, a clinical respiratory score of 4 prompts consideration of escalation of care. And so I won't go into this in detail, but this is a quick snapshot of our algorithm and how we manage our patients from a monitoring and intervention standpoint based on that clinical respiratory score. And as you see, the CRS score of 4 is where we consider transfer to our ICU. All right, so we've talked about the past, we've talked about the present, and now I think it's time for us to talk about the future. And why? Because we still have a long way to go. Let's go over some data to support that. So looking at acute chest syndrome outcomes at our institution. So I performed an IRB approved retrospective chart review that looked at over a 12-month period. And what we found is that we saw about 1,200 patients in our Texas Children's system. So that includes 3 hospitals. And of these, 150 or 13% of patients were admitted at least once with acute chest syndrome within the year. And 80% of those patients had sickle cell anemia, so hemoglobin SS or S beta 0, and at least they had a prescription for hydroxyurea. Now, of those 13% admitted with acute chest syndrome, 13% of them required an ICU admission. And so I guess one optimistic point is that, when I actually did this analysis for the first time when I was in fellowship, and that number was about 20%. So there was some improvement. But anything over, that's still a pretty significant amount of patients. And so we need to think a little more about, given our current management guidelines, what more can we do to improve outcomes? So I talked about this clinical respiratory score, and I also discussed the clinical severity index. And while the clinical respiratory score is widely accepted and used at our institution, we hadn't quite analyzed the utility of it in predicting acute chest syndrome severity. And so I developed a study to identify the relationship between our clinical respiratory score and then using the NHLBI clinical severity index. And in conclusion, we did find that in our pediatric and adolescent sickle cell population admitted with acute chest syndrome, the peak clinical respiratory score significantly correlated with the severity of acute chest syndrome, such that patients who had a clinical respiratory score, like all patients who were in the ICU, or all patients who had severe acute chest syndrome, all had a clinical respiratory score of 4 or greater. And so that may suggest that patients who have a CRS score of 4 may be at increased risk of severe or very severe acute chest syndrome. And so this really highlighted the fact that, we're already doing interventions to say, like, at a CRS of 4, we need to admit, but it also makes us take a step back and say, can we prevent this trajectory at a CRS score of 2 or at 3? And what more can we do to hopefully change that trajectory? The study also just strengthened the utility of using the clinical severity index from the NHLBI to be used as an outcome assessment tool to assess how our interventions are improving outcomes. And I think it can be applied more broadly, even outside of our institution. And so that has been a labor of love, and I've actually submitted that manuscript and it's under review. So fingers crossed. Yes.
The ability to intervene.
Yes.
13% that went to the ICU. Do you have a sense of how many of them went to the ICU on admission or within 24 hours that they were already presented ill versus how many of these they developed that severity over a period
Yeah.
of time?
Good question. And so what we saw is that the average time from admission to ICU admission was typically within that 72-hour period, which is very consistent with the data from 20 years ago, versus those who had a peak score of less than 4 who never went to the ICU. They typically peaked within 12 hours and then kind of improved from there. So it does show that, that's like a critical period. And so when we start to see that, we probably have like 24 hours to potentially change that trajectory. And we'll talk about a couple of things we can do and a couple institutions have been doing to maybe change that trajectory. So great question. So getting into prevention. So, one important thing is making sure that we're reducing the risk of hypoventilation, because I think a lot of what's happening is that with inadequate pain control or with inadequate lung expansion, we're causing this atelectasis, which is increasing risk of acute chest syndrome and severe outcomes. And so, incentive spirometry, like I said, super important, and it's been shown to reduce the rate of acute chest syndrome by up to 40% in some studies. And we even will, for some of our patients that are high risk, if they're calling us saying they're starting to have pain, even if it's not about that time to like come to the hospital, we will tell them, we will send them home with an incentive spirometer and tell them to start using their incentive spirometer before, as soon as pain presents. The other thing that colleagues at Boston Children's have looked into is early NIPPV or early BiPAP. It's been demonstrated to be feasible, well tolerated in clinically stable children with sickle cell disease, and both those hospitalized with and without acute chest syndrome. And in the Boston study, the BiPAP patient cohort had no adverse events, and 88% of those at risk for acute chest syndrome did not develop acute chest syndrome during admission. So this is something that, we've been thinking about a lot. One of the challenges is that from an institution and system standpoint, we used to have a step-down unit, and now it's either the floor or ICU, and BiPAP is typically an ICU threshold. So, I think it would be like a systems discussion to see if we can initiate early BiPAP sooner than later, because I think it could improve kind of the trajectory of our patients. Other important things we've already kind of highlighted, so preventing infections, penicillin prophylaxis, timely immunizations. It's important to make sure that we're controlling asthma in our patients with asthma and sickle cell disease, and then reducing vaso-occlusion. So hydroxyurea, mainstay treatment. Chronic transfusions are reserved for some of our patients, and then newer meds, which we'll talk about later. Controlling pain while minimizing oversedation. And then another point I want to make is optimizing our patients pre-op. And so if they're having surgery or some major procedure that requires anesthesia, we have protocols in place to make sure that based on the risk of the procedure and the risk of historical risk of the patient, we will make sure that we optimize them through transfusions, hydration, and oxygen support. Disease-modifying therapy. So hydroxyurea has been a mainstay, and several studies have noted that it markedly decreases the frequency of acute chest syndrome in both children and adults. L-glutamine has also been demonstrated to increase the incidence of acute chest syndrome, especially in children. And then 2 medications, crizanlizumab and voxelotor. There hadn't been enough supportive data to recommend either of them even before most recent updates. And there was actually a case report of a patient with sickle cell disease who was on crizanlizumab, stopped crizanlizumab, and then developed acute chest syndrome soon after. So it is definitely something I have pause in terms of using it specifically for acute chest syndrome management or prevention. And then as we know, voxelotor, now it's not an option. But anecdotally, we did have a patient who had this rapidly progressive phenotype who was typically fine throughout the year. But when he had acute chest syndrome, it was pretty severe, went to the ICU, had the thrombocytopenia, and we did put him on a voxelotor, and he didn't have any more severe episodes. So it was very helpful for him, but that's not an option anymore. And so I do think that this gives us an opportunity to take a step back and think about what other medications or therapies we can use to continue to improve outcomes in acute chest syndrome. So I see this as an opportunity. And all of these have led me to a key question when thinking about my translational fellowship project, which started 3 years ago. So looking more at what cellular and molecular factors contribute to acute chest syndrome severity in our patients with sickle cell disease. So here is a schematic looking more so on the cellular and tissue level of acute chest syndrome. And as you see within the pulmonary vasculature, there's sickle cell vaso-occlusion, which also involves platelet aggregation and neutrophil, or platelet activation and neutrophil aggregation. And what this can do is it can lead to this diseased inflamed endothelium and migration of neutrophils and other inflammatory cells into the alveoli, which can cause ultimately lung injury. And so the first pathway of interest, and which is a part of my co-I work on the R1 with my mentors and colleagues, are looking at the inflammasome. And so this is kind of a schematic of the NLR, or not-like receptor protein 3, or NLRP3 inflammasome pathway. And as you know, sickle cell disease is a hemolytic disease. And then hemolysis will cause the release of free heme systemically. Heme is a known pro-inflammatory molecule, which is called a danger-associated molecular protein, or a DAMP. And it triggers the formation of NLRP3 inflammasome in both macrophages and monocytes, which are primed with lipopolysaccharide or other pathogen-associated molecules, which we call PAMPs. And the activation of the inflammasome increases the release of caspase-1. And then that activates and releases IL-1 beta and IL-18. And this induces this inflammatory cell death process called pyroptosis. Also important in the inflammasome pathway is that IL-1 beta and IL-18 can be also released through this NF-kappa beta pathway. And this is through the interaction of heme and PAMPs like LPS with the toll-like receptor 4. And more recently, studies have discovered that toll-like receptor 4 can also activate the NLRP3 inflammasome in platelets, and this demonstrates a direct link between the inflammasome and the NF-kappa beta pathways. And so, since sickle cell disease is a pro-inflammatory hemolytic disease, both of these pathways can be very important to explore in the setting of complications like acute chest syndrome. So more on IL-1 beta and IL-18 in acute chest syndrome. So there have been studies looking at transgenic sickle cell disease mice that found a couple important things. So one, increased NF-kappa beta expression in the lungs. Two, heme-induced toll-like receptor 4 activation of the NLRP3 inflammasome. IL-1 beta activation of cells like neutrophils, platelets, and the endothelium. And this all can result in the formation of this large platelet neutrophil aggregate, which can lead to pulmonary arterial occlusion. So in fellowship, I was looking at a lot of different cytokines and inflammatory signals in the setting of sickle cell disease and then in acute chest syndrome. And so I used this multiplex assay to look at things including IL-18. And what we found is that IL-18 at steady state is markedly elevated in patients with sickle cell anemia, and they're significantly elevated. However, when I tried to stratify by historical acute chest syndrome severity, we didn't find a significant difference in between the populations. But what this may reflect is that this is just a general signal of heme-induced chronic inflammation in sickle cell disease. And while IL-18 and IL-1 beta may not be the primary drivers or indications of acute chest syndrome severity, they could be factors in priming for inflammatory mediated conditions and acute lung injury when exposed to pathogens and other insults. And so I will continue to work with my colleagues to look at if there is a way that we can look at the inflammasome pathway in specifically acute chest syndrome to see if there are additional links outside of just looking at steady state levels. So looking more in pathways to see that relationship. And it's important because there are two therapeutics that are currently in trial looking at both IL-18 and IL-1 beta. So there is the IL-1 beta blocking antibody canakinumab that has been studied in sickle cell disease, more so related to pain. And while there wasn't a significant difference in pain outcomes particularly, they did demonstrate a reduction in hospitalization and hospital length of stay. There's also an IL-18 binding therapeutic that's undergoing clinical trials for therapeutic inflammatory diseases. And so these are two things that may be considered in the future. But as I had these results and looked at it, I started to think more about, is there something that can be more lung specific? So one thing that's been very promising, and actually one of the studies was led by one of the UAV colleagues, actually, is looking at hemopexin in acute chest syndrome. And so essentially extracellular hemin can contribute to acute chest syndrome pathogenesis through the toll-like receptors. And recombinant hemopexin, which is a scavenger protein of free heme, has been shown to be a potential therapeutic agent in acute chest syndrome. Actually, Dr. Sadoun, I don't know if he's here. He's online. So a special shout out to him. He published in Redox Biology about environmental triggers, specifically chlorine-induced acute lung injury. And hemopexin was a way to actually help recover from acute lung injury. And so hemopexin may be pretty promising in terms of a potential therapeutic for acute chest syndrome. And then now focusing on my current focus in research, so bone morphogenetic protein 9. So as background, BMPs or bone morphogenetic proteins are molecules within the TGF-beta superfamily, and they're involved in several functions. Most importantly, that signaling dysfunction is actually linked to cardiopulmonary disease. And there's a lot of literature out there about BMP signaling in the setting of pulmonary arterial hypertension. And so specifically, bone morphogenetic protein 9 is a selective endothelial protective factor. It's produced and secreted from the liver, and it is the primary circulating BMP in serum. It is a ligand for activin receptor-like kinase 1 or ALK1, and ALK1 has its highest expression in lung tissues. What we've seen clinically is that in pulmonary arterial endothelial cells, BMP9 has been shown to prevent apoptosis and excess permeability, typically triggered by LPS, TNF-alpha, or thrombin. And furthermore, in vitro studies and in vivo studies, they found that BMP9 is actually downregulated in the setting of inflammation, including sepsis. And there have been several mouse studies that have looked at different aspects of either giving or blocking BMP9. And so in giving exogenous BMP9 at physiologic levels, it was demonstrated to be protective when pre-treated in LPS-induced acute lung injury. On the other side, when mice had endogenous BMP9 and the BMP9 was neutralized, this led to lung vascular leak and ultimately lung injury. Looking more long-term, BMP9 treatment at physiologic levels on a longer term actually showed evidence of reversing pulmonary arterial hypertension. And so what this shows is that there may be a potential role in the development and treatment of acute and chronic cardiopulmonary disease using BMP9. So given that literature, I wanted to see what are the levels of BMP9 in our patient population. And so we measured steady state plasma concentrations in a cohort of pediatric patients with sickle cell disease with and without a history of acute chest syndrome. And this top graph demonstrates that nearly 40% of patients with sickle cell disease in our cohort had plasma BMP9 levels well below the lower limit of normal. And to remember, low BMP9 increases your risk of lung endothelium dysregulation. And so we actually want them to be at higher physiologic levels. Then I also compared the cohort based on acute chest syndrome history. And I found that patients with a history of acute chest syndrome had a significantly lower level of BMP9 compared to control patients with sickle cell disease without a history of acute chest syndrome. And the median concentration of BMP9 was about 46 picograms per ml, which is half the lower limit of normal. So then I took this a step further and looked at a different cohort. And I looked at steady state BMP9 plasma levels, and then I stratified by acute chest syndrome historical severity. And in this analysis, most patients with sickle cell anemia had circulating BMP9 levels lower than the lower limit of normal, which we saw before. But what was most notable was that the BMP9 levels were significantly lower in patients with a history of severe acute chest syndrome compared to those who had never had an episode. I then also looked at this from a different way. So looking at the circulating BMP9 by disease state. So comparing steady state to acute chest syndrome, those who have acute chest syndrome episodes. So we collected that plasma within like 48 hours of radiographic evidence of acute chest syndrome. And then we had an additional comparison group of a couple of patients who were admitted and had either a vaso-occlusive episode or upper respiratory infection without acute chest syndrome. And what we found is that still the median BMP9 levels during an acute chest syndrome episode were significantly lower than patients who were at a steady state. And we also saw that it was significantly lower compared to those who had admitted for vaso-occlusive episodes or upper respiratory infections. And so this makes me think of two things. One, this may be a more lung-specific biomarker for acute chest syndrome and severity. And then also knowing that majority of patients have a lower level of BMP9, this may suggest that this can contribute to the risk long-term of pulmonary hypertension, pulmonary fibrosis, and other chronic lung diseases. And so this gives us an opportunity to look further into what pathways can contribute to this, and can we harness this to both use as prognostic, diagnostic, and then therapeutic. So this is what my KO1 was focused on. So essentially determining the role of BMP9 in acute chest syndrome and sickle cell disease. And so my first aim is really looking at the natural history of circulating BMP9 levels and the fluctuation of that. And so the general hypothesis is that low BMP9 levels increase the risk of acute chest syndrome. So for this first aim, my goal is to kind of expand my preliminary research and analyze both BMP9 and other inflammatory cytokines at steady state, onset of hospitalization, acute chest syndrome event, and recovery, which we define as about 2 weeks after acute chest syndrome. We have two comparison groups, so age-matched patients with sickle cell disease without a history of acute chest syndrome, and then healthy individuals without sickle cell disease. The second aim is looking more at the mechanistic role of BMP9. And so the first sub-aim hypothesis is that BMP9 protects against inflammation-induced pulmonary endothelial injury. The way I'll approach this is that I will pre-treat pulmonary microendothelial cells with plasma from patients with sickle cell disease, and then I will either pre-treat or not pre-treat with BMP9, and then treat with known inflammatory triggers, including heme and LPS. From there, I'll assess permeability and gene expression, and that will be more so from a cellular standpoint. The second aspect is looking at how inflammation can suppress BMP9, contributing to acute chest syndrome. And so this is more of a Towns mouse model. And so we'll pre-treat mice with and without physiologic levels of BMP9, followed by heme and LPS, similar to the first sub-aim. Then we'll measure plasma BMP9 levels to see if they have any differences. We'll also pathologically or histopathologically evaluate the lungs. So looking at the lung injury extent of the lungs, and then we'll do some work looking at the BMP signaling changes through transcriptomics. Now this slide is especially dedicated to some investigators here. who do some very impressive work on endothelin-1. And so I wanted to look at endothelin-1 in the context of its relationship to BMP9 and its relationship potentially to acute chest syndrome. And so BMP9, as a review, maintains endothelial integrity, but it's also been found to modestly stimulate endothelin-1 for homeostatic vascular tone. Endothelin-1, in short, is a potent vasoconstrictor and a pro-inflammatory mediator, and it's balanced by BMP9 and healthy endothelium. But as we know, excess endothelial-1 can lead to endothelial damage and lung injury. So thinking about this in the context of acute chest syndrome, so hypoxia, hemolysis, and inflammation increases endothelin-1. Also, acute chest syndrome makes BMP9 lower, right? It suppresses it in the setting of sepsis or acute chest syndrome in general. And so both of these are this perfect storm of endothelial dysfunction and acute lung injury. So what does this mean clinically? So BMP9 and endothelin-1 can both serve as potential risk stratification biomarkers in the setting of acute and chronic cardiopulmonary disease. And then thinking about therapeutic goals, there are several studies and trials that have looked at ETA, or endothelin A receptor antagonists, and it's been shown to improve endothelial integrity and cardiopulmonary outcomes. But BMP9 supplementation can also balance the side effects that can happen with endothelin A, which can be vascular leak. And so maybe a combination of those can be synergistic to improve acute chest syndrome. So something to study, and I look forward to potentially collaborating in that setting. So here's just a review of some of the newer proposed therapeutics in the setting of acute chest syndrome. So we talked about the inflammasome and caspases, which include IL-1 beta and IL-18. We talked about hemopexin to kind of address the heme-induced hyperinflammation in sickle cell disease, endothelin A blockade, and BMP9 supplementation. So what are my big picture future management goals in acute chest syndrome? So first, we have an opportunity to gain better understanding of predictors of acute chest syndrome severity. And so that allows us to think about how we can develop new screening and prognostic tools, which I tried to highlight today. Also, new biomarkers and interventions. So that can include immune modulation and optimizing lung endothelial health. It's also important to make sure that we're tailoring our interventions based on age, severity, and other risk factors. And we talked about a couple of tools to be able to potentially do that. And the biggest, most important goal is reducing morbidity and mortality in sickle cell disease due to acute chest syndrome. So, big picture summary, acute chest syndrome is common, leading cause of morbidity and mortality in our patient populations. It's super important to have early diagnosis, treatment, and frequent monitoring. We discussed prevention strategies focusing on optimizing lung health, preventing infections, and reducing vaso-occlusion. And for current management strategies and risk prediction tools, there are opportunities for further optimization. All right, so as I'm getting to the closing, I wanted to just briefly talk about my why. Why do I do this? Why do I care about this? And why am I here? So, first, I have personal family experience with sickle cell disease and acute chest syndrome, and that started right here in the Birmingham metropolitan area. Fun fact, my mom is from Bessemer, Alabama, so right down the street. And one of my cousins, which I did not know until medical school, I knew that he unfortunately passed away from lung complications. We were told a bad asthma attack. But as I came to Bessemer to stay with my grandmother while I was studying for step 1, I needed just someone to support me in as minimal distractions as possible. I talked to her about how excited I was about learning about sickle cell disease and what I wanted to do to improve health disparities. And she mentioned, she was like, your cousin had sickle cell disease. And I was like, what? And it really put a lot of things together, having the chronic ulcer on his foot that nobody knew what was going on, And then thinking about how he rapidly deteriorated with this bad asthma attack, I thought, and I was like, you know what? He had acute chest syndrome. And it was the perfect picture of that. And so that's one of the reasons why, I want to do what I do, and I want to improve outcomes to make sure that people like my cousin have a better outcome, and that we're able to have standardized guidelines to be able to do just that. And so this is almost feels like a homecoming being here, and I'm super excited and grateful for you all listening to me. So I wanted to this is my slide to give a shout out to all of the mentors, collaborators, leadership who have supported me in this process and who have funded me to be able to do so. And my final slide are my other whys. So this is my little family. My son, it's actually, fun fact, today is his second birthday. So we celebrated at Chuck E. Cheese, but it's been a long time coming. This first picture was about 2 weeks after he came home from the NICU. He was a NICU grad, and this was my first year as an attending. And I was like, how am I going to do all this? And as you see, we have all grown and we have all thrived, and I wouldn't be able to do it without them. So thank you all for listening. I invite any questions, comments, concerns, and thoughts. Thank you. Yes.
I learned a lot. As a kidney guy, I don't really know that much about acute chest, so it was great to hear that. I do know something about endothelin, and I'm curious about endothelin antagonists are used for pulmonary hypertension. Has no one looked? I did a med search. No one's really looked at whether they would be useful, because all the things you described, endothelin, blocking endothelin, seems like it would be a benefit. Nobody's, not even a case study or anything.
Oh. And so, yes, there hasn't been, and so that's like it's a prime opportunity. And that was the same with BMP9. I was like, oh, there's literally mouse studies in acute lung injury, but no one's looked at it in sickle cell disease. And so I'm hoping to fill that gap to get more knowledge and see if that's an opportunity.
Kind of along the endothelial cell line idea. Do we know if acute chest or severity is associated with endothelial dysfunction? Has anybody looked at either nitric oxide biomarkers or flow-mediated dilation after acute chest or anything like that?
Yeah, so there have been some studies that have looked at nitric oxide, but not like sustained. And I haven't been able to follow up to see like what the latest. I know nitric oxide in isolation or by itself hasn't been shown to affect outcomes significantly. And so while I think that it can be something potential to contribute, and I think L-glutamine also kind of gets into that too, because it does affect the nitric oxide pathway. And so I think it's something that can be looked at as like an adjunct. But there's so much opportunity to look at these pathways, and it hasn't been looked at further. So a lot of these questions I have, and I'm hoping to look at them myself and collaborate with others who are also interested in it. Yes.
Obviously for biomarkers, it's hard to do in real time. So have you been able to correlate, as you had mentioned, right? I see acute chest syndrome kid who's got a 3 gram necessary drop in hemoglobin platelets. Obviously that feeds all of our attention.
Yeah.
Have you been able to correlate any of the biomarkers that obviously you get later, but going back to that presentation with change in either white count, ANC, platelet count, hemoglobin from baseline, to see whether or not any of those correlate?
So that's a good question. And I think I have 2 patients who had something similar, like have this rapidly progressive phenotype, and I'm actually isolating things. I want to save them just until I have everything, all of my assays and everything pretty standardized before I use them, because they're so very rare. But that's something that I'm really going to be looking at as well to see particular on a molecular standpoint, is there something different that happened in them compared to the other patients? So definitely in progress. Yes.
So the BMP9 during lung inflammation is downregulated.
Mhm.
And then it looked like at steady state, patients who had a history of severe acute chest syndrome have lower BMP9 levels. I
Mhm.
was wondering about your hypothesis of sort of the order of that cause and effect. Do you think that patients at baseline have a lower BMP9 and that's why they get those? Or do you think that there's this chronic inflammation in those patients that are just suppressing the BMP9?
Yeah, and that's what I really want to get into. And that's why that first aim is like really trying to look at the sequence of events. I mean, what I think is that some of these patients probably have a lower baseline BMP9, which makes them susceptible to acute chest syndrome, and then acute chest syndrome suppresses BMP9 and it becomes this kind of cycle. And so one of the questions is, how does that fluctuate? Is there any rebound increase in BMP9? And then also, are there certain subsets of populations that it's different in? And so that's a great question. And that's what I'm working on trying to tease out a lot more. So I think through looking at that natural history and looking at the mouse model, we may be able to more real time see what's happening. But that's definitely the question. Yes. Yeah.
Are there any correlations with non-sickle patients with pulmonary involvement of endocarditis?
Yeah, so the first question, the typical normal range of BMP9 ranges between 100 to 300 picograms per ml. And so our patients median are typically in the 50s, and during acute chest syndrome or those with severe acute chest syndrome typically have levels like 30s, 40s. Some have been as low as like 10. And so there was definitely a significant difference overall. And then the second question, so the initial, I talked about the mouse models where they had, but they also correlated with a subset of patients who had sepsis in the ICU. I think these were adult patients, and their BMP9 levels were lower than steady state in a non-sick cohort. So they are lower in non-sickle adults who have sepsis or acute lung injury, but it hasn't been looked at until now in sickle cell population. And the caveat to mine are these are pediatric patients, so as young as 3 and as old as 21. So it'll be interesting to see if there are any differences in the adult population compared to the pediatric population.
Just because I know your next talk, 9:45.
Oh.
So need to get you over there. Thank you very much. It's fantastic.
Oh, thank you. Thank you.